Welcome to Next Economy Now. The goal of this podcast series is to highlight the leaders who are taking a regenerative, bioregional, equitable, democratic, racially just, and whole systems approach to creating the new economy.
I'm Kevin Bayuk, a partner and worker owner at Lift Economy. My guest today is Dana Brown. Dana Brown is the Director of Health and Economy at the Democracy Collaborative, a friend of Lift Economy, where her research focuses on health and care systems, the pharmaceutical sector, and economic transformation for health and well-being. Dana is the author of Medicine for All, The Case for a Public Option in the Pharmaceutical Industry, published in 2019. Her work has also appeared in outlets such as Stat News, The Hill, The Guardian, The New Republic, and many more. Previous to the Democracy Collaborative, Dana was an associated project, was the director of the Next Systems Project. Again, one of our favorite projects at Lift Economy, which that's something that the Democracy Collaborative launched in 2015. It's a platform for really exposing the systemic failures of the current economic system and presenting kind of a plethora of alternatives to the existing system. I think it's one of the most important projects out there today. Dana, welcome to Next Economy Now.
Thanks so much. It's a pleasure to be here.
So, Dana, to start off, I'm curious if you could just share, your story or your journey. What has brought you to the work that you're doing today?
Sure. Well, I have a background in human rights work, and I spent many years doing work in Latin America or in the US, but with partners in various parts of Latin America. And really, throughout the hemisphere, human rights work is conceived very broadly. It's really about economic and social rights as well. And certainly, health is a human right, and that's very front and center for a lot of the movements and communities that I had worked with. But as I kind of grew in that work, I was beginning to understand the very policies and practices in my own country thwart attempts to kind of realize that right, health is a human right for many Americans. And for a long time, I thought, single payer was a no-brainer, right? But the more I looked into our healthcare system, the more I realized that the problems were much bigger than our insurance structure. So obviously everybody deserves to be covered and everybody deserves to have access to essential care. But I realized there were so many other issues, right? A focus on curative rather than preventative care, which kind of led to an overabundance of medical specialists and a dearth of primary care providers. But also huge geographic and racial disparities in access to primary care, but also hospital services. In some, I was seeing a real big mismatch between what a society needed to be healthy and happy and the structure and functioning of the healthcare sector that we have. So that led me to dig deeper and learn more about, the financing, the ownership structures, and the functioning of our healthcare system, but also to say, what alternatives are there? What things have been done before? What things could be done, differently, so that we have a system that more produces health rather than attempting to put Band-Aids on all of the health problems after they occur. And I guess one of the big aha moments for me was realizing not only does the US spend a lot more money on, quote, healthcare than any other country on the planet, but it's nearing 20% of US GDP. I think it's around 17-18% at the moment. It hit 20 earlier in the pandemic. Thinking about just sort of the quantity of resources, right? What could we as a society do if we reclaimed a fifth of the US economy and actually invested in the stuff that really does produce health and well-being? And I guess, there's so much literature, but also practice and, just knowledge from communities around the planet about the things that do create health. And we're kind of systematically ignoring those in the US healthcare sector. So that just got me riled up, but also excited about all of the potential that's there and the ways that, we don't even have to spend more on US healthcare. We just have to spend smarter. And I think there are lots of ways that it could be better for all of us.
Thank you, Dana. And thanks for getting riled up from observing these obscenities and then taking that energy and doing what not everybody does, which is to dig deeper and really try and understand the contours and specific structures and the cultural constraints and all the things that are creating this morass, a terrible problem that is betraying the potential for our, livable future in collective liberation and health for all as a human right. I'm really just appreciating doing that level of diligence takes energy, stamina. Some of the details are, some people would say, boring or difficult to understand. I think that's true. And you've had the courage to go in there, and I'm really grateful. And maybe you could tell us, you can respond to that as well. And maybe you could also tell us, how did maybe a little bit of history, but also how and why did power get concentrated? And what does that mean? If power is concentrated in kind of this health system, as you say?
Yeah. And I think you just said something that I think is really important, right? That, healthcare in the US is so complicated, right? And I think it's purposefully been made complicated, particularly the financing and the insurance stuff, right? There's sort of a lot of regulation around that, and there are a million little details and changes over time. I always joke my husband is not American born. He's been here for a number of years, but, I don't think he'll ever understand health insurance. And I just deal with the insurance stuff because I'm still learning every day, right? But I think, yes, there's a certain amount of complication. And if you want to do the work to transform the sector, you have to learn a certain amount. But I think for most people, the important thing to remember is it doesn't have to be that complicated, right? We have come to a place where we're utilizing 18% of the US economy for something and we're not getting bang for our buck, right? We have higher morbidity, mortality than a bunch of other countries, similar high-income countries. We have, horrific statistics on particularly Black maternal mortality, but also infant mortality across race and class. And these things are just unacceptable. So I think we can push back on the it's too complicated to change and say, well, a lot of countries, have done less complicated things with far fewer resources and are getting a lot more for what they invest. Why can't we do that too? So I like to engage with and push back on that. And then, I think it really goes to that question of power and control. I mean, many, many books are filled with, quote, the history of the U.S. healthcare system, and we could start at any point and it would be a long and complicated story. But I think just really briefly, I think we can point to an over a century-long trend towards more and more privatization and consolidation, particularly in the provision of care. And what I mean by that is who owns and controls and runs hospitals and clinics and your primary care facilities, et cetera, but also who makes medicine and distributes it and medical devices and all that. And, we've gotten to a point in that privatization and consolidation that, some major cities are left without even a public hospital at this point. Many geographies have a monopoly or a quasi-monopoly player where, a single health system owns and manages most of the care that's available, even primary care, right? Because they buy up these practices. But there's also been this tendency towards financialization of the sector, particularly in the, last half of the century, where private, but also nonprofit players are increasingly invested in financial assets over investments in the real economy. And what I mean by the real economy is productive stuff. So infrastructure, the actual building and the things that you need to run a clinic, and the human resources, right? The employees. So this creates a scenario in which we have massive nonprofit and private healthcare systems with huge investment portfolios and really highly paid CEOs that are simultaneously making a bunch of money from money, right? Investments in the financial markets and insurance and real estate. But at the same time, they're cutting salaries or staff or allowing shortages in key materials, right? And I think the clearest case of this trend, or sort of the sharp end of this, is where private equity firms have moved in and bought a lot of healthcare assets. They're piling hospitals and clinics with debt, downsizing staff, walking away with massive profits, and then dumping this bankrupt entity back into a community that still needs a functioning healthcare system, but is left with sort of a shell. And one example, I think, early in the COVID-19 pandemic, we heard a lot about private equity-owned nursing homes, where sometimes the staffing ratios weren't what they were supposed to be, right? There weren't as many nurses on call as there should be per patient. And also, the appropriate PPE wasn't always available. And it turns out that the morbidity and mortality was often higher in these locations than in public and nonprofit nursing homes. And investigations have shown that private equity actors were treating a lot of these nursing homes essentially like real estate assets. It's the packaging up the land holdings like real estate assets and buying and selling them in REITs and other things on the market. And so the focus was on this real estate as a way to invest and make money rather than the focus being on caring for people. So I think in some that gives us a little bit of a sense of how healthcare is really more and more been treated like a business, right? It's a commodity. It's a thing we buy and sell rather than a service that we provide as a society and in which we engage in to receive care and to care for others. So this whole kind of trajectory is really about power and ownership increasingly being concentrated in fewer and fewer hands. And then I think just one other symptom of that I think is pretty clear for people to see is that healthcare, including the pharmaceutical sector, accounts for the largest lobby in the United States consistently year after year after year. And I think that shows, right, that there's a lot of moneyed interests defending that system of private control and profit making to assure that they can continue to extract profit and, again, use healthcare as a business rather than a service.
Totally. And I think that resonates with what you said earlier, this lobbying effort to influence or control the apparatus of the regulatory apparatus has maybe purposefully complicated the whole situation to obfuscate what's actually happening, which is this, like you said, the financialization, the efficiency, the business orientation, the privatization and consolidation that's been happening in front of us. And to the person who's ill or in need of care, it's not necessarily super obvious all the machinations that have gone on kind of upstream to the provisioning of care that have led to these terrible outcomes for health and certainly health equity. So Dana, I'm going to ask like the totally unfair question, what can we imagine a health system looking like from here? Like how, if we were able to shift power or the institutions that provide provision care, what are some of the things that we should be looking for in terms of transitioning this system?
Yeah, that's a great question. It's not unfair at all. I think it's a really important question because, as a friend once said, right, if we don't know where we're going, we can't get there. Or right, if we don't know the final kind of state that we're trying to achieve, all paths lead there. So we don't know which one to take, right? I will say that I think there's more than one right answer in the sense that I think there are several different ways that we could have sort of the final structure of a healthcare system that worked much better in terms of sort of naturally producing more equitable and sustainable outcomes and consuming less of our total economy and keeping more of those dollars local and invested in the real economy, in the social determinants of health, in, having good jobs and good housing and a good environment for all of us. So I don't think there is one absolute right answer, and I don't think there's only one path that gets us there. So to me, the question is sort of what does a non-extractive healthcare system look like? One that actually centers, right, these social determinants, one that centers well-being and health rather than profit making. And I guess on sort of a broad level, I think there's two things that we need to think about in terms of what does that look like and how do we get there. One is I think it's pretty clear that we just need to curtail certain extractive investments into the health sector. And I think private equity is a pretty obvious one. I know that's hard given our sort of legal and regulatory structure, but I think the evidence has been mounting for a long time that that's just harmful for patients, but also for providers to be sort of forced to be making such profits in such a short period of time. That's just not what healthcare is set up to do. And then I think the second piece of that is equally or even more important is that current and future investments in the healthcare sector should go to public and community-owned institutions. And those can have several different forms. They could be at different scales, right? That can be more locally controlled. It could be federal, But I think that bit is clear, right? Public institutions, for instance, have much higher rates of unionization and employment of women and people of color than the private sector does, right? So that's good jobs. That's an upstream investment in health, right? This is helping us get at health equity both by spending more money on the actual health stuff, but also investing it into the kinds of jobs that, are a social determinant themselves, right? Public and community institutions keep more of their dollars circulating in local economies, right? And that has all these, compound effects on health and well-being. It also has compound effects on our impact on the environment, which is also a determinant of health, right? So there's kind of these multipliers that we can look for. And then I think, right, anchoring healthcare in a system of nested public and community-owned entities can help us recalibrate the purpose, right, the mission, and make healthcare about care and support again, right? The thing about public ownership, the thing about a community-owned and driven institution is that it's so much more flexible than private ownership. Privately owned entities have to maximize profit or they can't compete. Shareholders leave and they go somewhere else, right? There's this capital bias. Okay, money goes where it makes the biggest returns. And so I think there's a lot of work in the United States that's tries to tame business and make it do non-business like stuff. Whereas in healthcare, I think it's pretty clear that we don't need more profit-making business. We need more entities that can define their bottom line in a different way, right? So the bottom line isn't how much profit did we make this quarter. It's maybe maximizing community benefit, right? And we can talk about ways to measure that. And I think a lot of organizations that you work with work on that, right? What does the community benefit look like? Well, in healthcare, we can measure it by, reductions in morbidity and mortality and reducing inequalities, but also these other things that we know are structural determinants of health. So I think that's what it's really about. And it can take a bunch of different forms in terms of, campaigns and actions, right? Some of that's trying to save the public hospitals that we have, right? Trying to make sure that rural hospitals don't get closed or bought by private equity, right? Some of it's defending what we have. Some of it's scaling things that we know work. Some of it's converting things that are currently noxious into something that is much more community-driven and centered on health. So I think there's a bunch of multiple inroads. Yeah, we have to deal with the financing thing, and health insurance is a piece of this, but it's not the totality, right? Even if we had a single payer system where, we all paid for healthcare through our taxes, if we don't deal with this issue of who's providing care and how evenly distributed it is, then we're still going to have, it's just going to be like a big government payout to private industry, which we've seen in a bunch of sectors, and that doesn't naturally produce equitable results, right? So we got to deal with both.
Thank you for all of that, Dana. So the kind of, if I could recapitulate some of it and see if I'm tracking, the major arc here is this shift to a non-extractive health system that authentically centers well-being, equity, health. And on that long horizon, there's a number of pathways to get there, a number of actions, types of actions at different scales to navigate towards a system that can reallocate that enormity of resources towards the actual, human right of health and well-being, and looking at the social and environmental determinants that actually lead to, we know, like you said, there's evidence around the world that is clear that those aspects of life and society do have impact on health. And so you gave some examples, and one frame that sometimes we think about at Lift Economy is there's triage actions and some things that are transitionary toward, and then there's the maybe transformative to that more ideal or the possible livable future kind of model that does center well-being and health. And so in triage, you said, let's curtail private equity and the profit-driven pressures. Let's defend some of the things that do exist and make sure that they are able to continue existing. So there's kind of some triage work. And then there's, transitioning towards more public and community-owned institutions, especially in the context if public institutions are responsive to public needs, which is not always the case in the very cynical, lens of the could be maybe because of that corporate capture of governance, right? And that means of the regulatory and subsidy apparatus. But I love what you said, in the recap that really caught me is like, if those public and community-owned institutions were nested in the purpose of a health system to actually provide for well-being and health, and then all of that resource can get that stacked multipliers, you said, I think, like where we can have all of those social and environmental determinants of health as in the consideration nested within a health system, whereas right now they're kind of like external to and forgotten about, or not, where resources are not allocated. So that was a very poor recapitulation, but I want to make sure I did it.
No, that's great.
Okay. Is there anything that you would add that I missed in that?
Oh, yeah. I think you brought up some great points. And you make a really good point, right, about sort of publicness is sometimes a necessary but insufficient factor to get the kinds of things we need, right? Just because something's public doesn't mean that it's optimal, right? Or that it's maximizing public return on public investment. No, and I think a lot of times in healthcare, we think, just like make insurance public, we're cutting out the profit bit, all our problems will go away, healthcare costs will go down, there'll be more. No, I mean, again, like I said, this sort of great coup of public ownership is just that it's flexible. It doesn't mean that it's perfect just because it's public. You still need to design it. We need to think a lot about governance and transparency and participation, right? But I think there's some, fairly decent models out there. I think there are existing bits and pieces in the US, there are models from other places, there are models from history. And I think part of the rub is, right, looking to see what does work in our strange context of the United States healthcare landscape. What could be scaled? What could be done even better, right? That's already functioning, well, but could use some further innovation to meet, current and future needs, right? So, yeah, I think that's a really important thing to say that, the ownership structure is, I think, fundamental to kind of getting the returns that we need for, health benefits and for the economy, but it's not the only factor, right? And the work doesn't stop there, right? Just because we created a new public thing or we nationalized a thing or we prevented the privatization of a thing, it doesn't mean that it's designed in a way that doesn't also just follow those extractive tendencies, right? Big public and nonprofit hospitals often give huge contracts to really extractive companies to provide their cleaning services or their food or the electricity, right? And they do that because they're embedded in a larger system that says the best outcome is always the cheapest outcome. Competition provides the best results, right? And that's just not the only metric there is, particularly for community health and well-being, right? But we have to all participate and we have to teach these institutions to do it in a way that really works for all of us.
That really highlights the need for, at an abstract level at least, the orienting around what are the measures that we're orienting the system towards. And you mentioned really centering well-being and health and equity. And there are measures that other places, other countries, other regions of the world do authentically use to center those things. And it's self-evident that here, at least in the US context, that those are not the measures. There's too much emphasis on efficiency and like cost of efficacy, which has betrayed the public right to health. You mentioned models and existing bits of what do work, or models that could be outside of the US context, or existing bits within that do work. Are there some that come to mind, that projects, initiatives, or even policies that you're tracking or advocating for that you want to highlight for Next Economy Now listeners so that we could be aware of like what are the things that we might want to support in whatever way we can?
Yeah, absolutely. I think there's several models in the United States that are really important to take a further look at. Two of the big ones are community health centers, federally qualified community health centers, which we could talk about. And the other one is the Veterans Health Administration. And I want to start there because I think probably most Americans don't know much, if anything, about the Veterans Health Administration. And I think it's a really outstanding example. Again, it's not perfect at the moment, and I don't think vets would say it's perfect. But I think it shows a lot about what could be done if you design healthcare systems differently in the United States. So The Veterans Health Administration is the US's only national coverage, fully integrated public healthcare system. It's very much set up like it's a beverage style system. So that means, like, if you know anything about the NHS in the UK, that means that both the payments, right, the financing, the insurance bit, if we want to think of it that, and the provision of care are both public. So we're both, paying out of tax dollars, but also with the employees who run the VA are public employees. There are a lot of interesting things there, right? If you're having the payer and the provider is the same, there's sort of, you're internalizing the incentives to do things efficiently. But efficiency in medicine means like following evidence-based practice rather than doing the high-priced new thing that maybe doesn't have the same gains as like investing in primary and preventive care. So the VHA, the Veterans Health Administration, has actually been really innovative in U.S. healthcare, finding the best ways to kind of do a lot with little amounts of money and getting the most bang for buck. So I think there are a number of things to point out. One is that any veteran who accesses the VHA has a primary healthcare team that they're assigned to. I think it's about 5 people. So there's a doctor or an NP that's sort of the lead primary care provider. There's a mental health provider who's part of that. There's a pharmacist who's part of it. And there's somebody who I believe coordinates social services and makes sure that the individual has the other things, right, those social determinants that they need to be able to comply with medical care and to be able to live a healthy life. And that's something that most of us in the private market don't have any. You can't even pay for that kind of service unless you have like really high top concierge care. And then there's all sorts of other innovations. I mean, there's a single electronic health record system for the whole VA. So you could walk into a VA in Idaho and be seen for something and then drop off the face of the earth for a few decades and pop up in Hawaii and walk into your local VA and they have all of your records. Again, something astonishing. And just, there's a lot more detail to it, but I think it's really interesting to note that the VA's patients in general come in with more complaints, more healthcare issues than your average Medicare patient, but the VA gets better results for less money than your average Medicare patient. So, and there've been really interesting studies that compare like vets who use the VA or vets who use the private sector. And again, it looks like the VA system is just getting more bang for their buck. They're getting better and more equitable health outcomes at a lower cost than the private sector. And there's a lot of different theories about why this is. Oh, it's really integrated. You're not losing people. You're not running duplicative tests. There's, all sorts of, the care is specific to the veterans population, right? They have a mandate to serve a really specific population. They learn about the particular medical needs, right? But it makes you wonder, like, why can't we have systems like that for all of us? Could the VA itself be expanded? It currently doesn't serve all veterans because Congress doesn't want to appropriate the amount of money that it would mean. So there's a lot of restrictions. Only some vets qualify. Well, what if all vets qualified? Wouldn't that be more cost effective for everybody? Wouldn't that be better healthcare for everybody? What if you expanded it beyond that? Or there's some VA hospitals, there's some infrastructure in the VA where they don't have as many patients as they used to, right? Like a place became really expensive and a bunch of retired vets moved elsewhere. So I think Palo Alto is a place, right, where it's gotten really expensive and they don't have the same veteran population that they used to, but there's already this infrastructure that's there. Well, what if we repurposed that? Could that be a community health center for that community? Why not? Right? Like we have a thing, it's been working really well. It's been shown time and time again to be cost effective, but also more equitable and getting the results. Can we repurpose that public infrastructure? So I think those are interesting things to wrestle with. And then very quickly, I also mentioned federally qualified community health centers. Those are, again, integrated primary health care clinics. They are publicly owned and run often by nonprofits. I think it's really important to remember that these came out of the civil rights movement. This was a demand of civil rights leaders to have healthcare for medically underserved communities. So now we have a network of over 1,400 federally qualified community health centers now. And again, the studies have shown time and time and time again that they're getting better and more equitable outcomes for these low-income patients than similar patients getting care in the private sector. they're doing it for less money, and they're spending more of their actual money in local communities, which has these other benefits. And then lastly, I think something that's really important about the design of community health centers, which again, we could imagine borrowing and using in other parts of the healthcare sector. One of these pieces of governance is that their boards are multi-stakeholder boards. And at least 51% of the board of any community health center has to be made up of patients served by that community health center. And there are other restrictions about conflicts of interest, right? No more than a certain percentage of the board can make their living in the healthcare sector. So the board is designed so that the healthcare center can meet its mission to be focused on the particular healthcare needs and the structural needs of the community they serve. I think we see that it works. So again, like, what would it be like if all Americans had some version of a community health center for their primary care? Wouldn't that be cheaper? Isn't it effective? Doesn't this model of governance seem to work? There are probably things about community health centers structurally or in some locations that we think aren't perfect. Great, let's make it even better, right? We've had this experiment, we've had whatever it is, 40, 50 years to learn how they are working. They've been heavily studied because they're public and the data is public, right? So now, together we can make them even better in the future. But why don't we invest more in these kinds of things that we know work and less in the stuff that seems to just, constantly leave communities with the bill?
Totally. And for clarity, the VHA, I'm guessing, is funded out of Department of Defense. Is that?
It has its own budget, but it is globally under the Department of Defense, and there's long history there about times in which it was better funded and less better funded and all that kind of stuff. But there's some fantastic resources out there. There's great books written by economists and historians who had been, asked by their editor, design a better healthcare system for the United States. As they're doing their research, they stumble on the VA and they're like, maybe I don't need to design a new thing. Maybe we're already starting to get it right. So it's really interesting. And I don't think the VA at the moment would be called perfection, but I think there's an awful lot to learn. And I really, I encourage people to take a look at it before thinking, we need to import a model from another place or totally overhaul what we have, because it's a big deal. And politically, culturally, it may be tough to sell, right? Rather than saying, we have a homegrown model, or we figured out how to make it work in this funky place that is a federal system where states have lots of, all these, we figured out how to make it work in America. Can we make it even better? Can we scale it?
Totally. And the federally qualified health centers, I'm assuming it's probably a mixture of Health Resources and Services Administration or Medicare reimbursement, or maybe also state funding. Do we know how those are funded?
Yeah, there's a mix. And don't quote me, I don't have it pulled up, so I won't get it all right. But yeah, there is a certain amount of appropriations every year or every couple of years that is a baseline budget for the community health centers. And then, yes, a lot of the patients are Medicare and or Medicaid. And so a good portion of the revenue does come in from reimbursements from that population. And then, there's probably a little variation too. I'm sure some of them are set up as nonprofits and actually do, bring in some grants or do some fundraising locally as well to supplement and offer certain other services.
Totally.
And each community health center looks a little different, right? Because its mandate is to serve a very specific population, right? It'll be like there's work at the federal level to designate medically underserved communities. And then you'll see, right, medically underserved community, this tiny little geography in this city is composed of a lot of people X, right? Okay, so this clinic, this population is primarily African American, or this population is primarily LGBTQ, or this population is primarily, Native immigrants, etc. And so the services and the functioning of that health center reflect those specific needs. So some health centers have, much more multilingual staff and services, right? Some health centers have much more, gender affirming care because that's a specific need of the population. And that's represented on their board, right? So that's the way decisions get made are made with the input of that community. And I think that's something that we could think about, like kind of irrespective of other things. What can we learn from that might be helpful in other healthcare institutions?
Totally. And so what I'm hearing is there's no shortage of inspiration in the existing landscape for both harm reduction today, triage, but also just transitioning to more responsive, locally owned, locally governed, locally controlled, public and community-oriented institutions. It's not tabula rasa. We don't have to start from scratch per se. There's enough out there that even here in the United States that have been, like you said, well studied, publicly studied, that we could leverage to build this, grow an effort, because it's already there, to have this kind of. Some of it might be a mosaic of approaches. There's no, like you said, there's no silver bullet or no single monadic kind of like, this is how we solve this problem.
And, we could think about, revolutionary changes, right? And just tabula rasa, right? Redo the whole American healthcare system. But I think we could also lean the other way and say one of the advantages of this strange federal system is that states can be the laboratories of democracy. You see, states can innovate and do things in a different way and then show, right, this model worked. Okay, another state can replicate it. Or I'm going to talk with my neighboring states and we're going to be a coalition, and as a region, we're going to do something new. And you see a lot of that innovation in the healthcare sector. Everyone wants to solve for healthcare. Everyone wants to do better by their constituents that way. So, like, you have the state of Montana that runs a public clinic for public employees. And they found that they can more cheaply and equitably provide, a primary care services and I think some secondary care to their state. So instead of buying a private health insurance plan on the market and providing care in the private sector, they just did it all publicly. And they're like, well, this works better, right? Maybe other states are going to do things like that, and you see regions talking about like banding together and buying drugs in bulk, right, for public programs, right? There's all sorts of people are hungry to solve these problems. And I'm not saying that it's easy or that there are no challenges there, right? We are up against the biggest lobby in the United States. We're up against powers that are used to having control over almost a fifth of the U.S. economy and enjoying that, right? But there's also a ton of room for experimentation. There's a ton of room to do things at the local level. And I think it behooves us to focus on that, right? To focus on what we can do and what we can get away with.
Sure. Yeah. I like that. And part of the growing of the next economy is focusing on what we can get away with in the context of the business as usual. We see that all over the landscape. So those are great examples. And I think it speaks to if we weave together a systems view, it is going to be this kind of mosaic of different approaches that's not science fiction. They do exist here and in different places. It's just that kind of systems orientation is rare. And like you said, it's actually maybe purposefully been made complicated. It's hard to see the through line to a system that works, but it doesn't mean that there's not both action being taken by passionate humans and that there's not possibilities to democratize power and really create and reify these pathways of change. I know you've written a lot about pharmaceutical sector as well, and I'd be remiss if we didn't touch on it. And you just kind of mentioned that, efforts to collectively purchase, as an example, to lower the costs. But I'm curious if, just because I know it's something that there's action around and stuff is happening, can you say something about the pharmaceutical sector and how this fits in this whole transmission?
Yeah, absolutely. Thanks. And this could be a whole episode on its own, but it doesn't need to be. And I think one of the links to remember is that, in recent years, right, pharmaceutical spending has been the fastest growing piece of that growing healthcare dollar, right? So if we want to do something about extraction, it's a good place to look, but also it really resonates with people, right? I think at this point, everybody knows somebody who at some point couldn't afford their medication. And that's a crisis, and that's unacceptable in a very rich and highly technically advanced country. But also, the more you look at it, the more the current pharmaceutical sector is just this pillar of a neoliberal extractive industry. And if you do the history, you'll see that actually the Chicago boys sort of trained some of the leaders in the pharmaceutical sector, your Pfizers and others, to think about ways that they could implement this neoliberal model, that they could financialize their industry and be more profitable, but not necessarily more productive in terms of producing the medicines we need at prices that we can afford. So I really got into this work by saying to myself, sort of the big unanswerable research question that was my entry point was, if the current industry is a pillar of the neoliberal extractive economy, what would a democratized pharmaceutical industry that could be a pillar of the next economy look like? What would it look like if it was designed to drive equity, sustainability, right? What if it was designed to make the drugs we need at prices we can afford? And again, I think the answer is there are a couple of ways to do this, but I think there are a lot of arguments for having at least some of that infrastructure in the hands of the public. So the whole pharmaceutical supply chain goes from, research and development of new drugs, which at the moment involves a lot of patenting and other intellectual property, and sort of that's where a lot of the capture is and a lot of the extraction. But you also then have manufacturing, wholesale distribution, right, all the way down to your retail, going to your local CVS or Walgreens or whatever. And I think there are opportunities at each of those points in the supply chain. The biggest leverage is up at the front, right, in R&D and making new medications, because that's the point of greatest extraction at the moment, right? That's where all the power is. A lot of these big pharma companies actually don't make that much, but they do buy and sell a lot of patents, right? So they're like a team of lawyers that just hoards intellectual property as a way to extract value when they may not actually be developing many new drugs. So if we intervene there, I think we get a lot of bang for our buck. But that's the tough place, right? That's the place that costs the most money. That's the place where you get the biggest resistance from big pharma. That's the place where you're meddling in intellectual property law, blah, blah, blah. It can be done differently. We, even in the US, have done it differently at points in time and in certain subsectors, right? The state of Massachusetts does R&D in the public sector and creates monoclonal antibodies and immunotherapies and vaccines, and they've been doing it for more than 125 years. The state of Michigan used to, but that lab was privatized in the 90s. At the time of privatization, it was the only manufacturer of the anthrax vaccine in the United States. And then the new private owner failed to make an FDA-approved anthrax vaccine for 4 years during an anthrax scare. So there's some interesting cautionary tales there. But the Department of Defense still does a lot of R&D in the public sector, right? In vaccines, in infectious diseases, right? Because they're thinking about their military personnel, but it also has huge public health implications. And there are bunches of examples. Anyway, we could do it all in the public sector if we wanted to, or we could do certain critical parts of antimicrobial resistance, high-priced cancer drugs, or we could invest a certain amount that we already give to the NIH, but we could keep that in the public sector and bring drugs all the way through to market. But we could also manufacture in the public sector, and states are starting to think about that. So you may know that California passed 2 bits of legislation to support bringing insulins, naloxone, and then later other drugs to market via the public sector. It's currently set up as a public-private partnership, but it doesn't have to be done that way. And there's a door open to do that fully in the public sector in the future. And I think that's an interesting place to think about industrial strategy and local economic planning, right? Again, if those are public sector jobs and you get more women and people of color in them and there are higher rates of unionization, what are the knock-on effects for public health in your community, right? But also, what are the knock-on effects for a resilient supply chain? If we're not importing everything that we need through producers in India and China, not that this needs to be jingoist or anything, right? But literally, we're just going to have more climate disasters in the future. And right, if your supply chain is closer, then that's better for the environment, but it's also more resilient. It's there when you need it in times of emergency. So I think there are a lot of potential multipliers, right, that we can think about. And then lastly, just not to leave it out, you could also do distribution in the public sector. And that's maybe doesn't sound super exciting, but it's also a way to save money, to assure that the drugs that are needed get to the places they're needed. And currently, that wholesale distribution piece of the market is actually one of the most concentrated. There's really only 3 major wholesale distributors in the United States. And so I think one very important example to throw out there, everybody knows how important insulin is to diabetics, particularly type 1 diabetics. And it's been in the news a bunch, and the big 3 insulin manufacturers last year were like, okay, Congress doesn't need to regulate insulin prices. We're going to lower insulin prices. We're going to start, selling this insulin product for $35. Well, one of the wholesale distributors decided not to carry the cheaper insulin because it doesn't help them as much, right? Their prices, what they make, is based on a percentage of the wholesale price of the drug. So if insulin all of a sudden is being sold for $35 instead of $300, they decided it wasn't as profitable. But what does that mean to patients? A patient goes to their local CVS, their CVS has signed a 10-year contract with that one distributor to source their drugs. So a patient can show up in a geography and go to 17 CVSs and Walgreens, and nobody's bringing the cheap insulin to them. Well, the public sector doesn't have the same incentives, right? You don't have to do everything at the cheapest rate possible. You don't have to make money, right? So what if the state of California or the region of the Northwest or the Midwest or the Northeast or whomever is a public distributor and retailer, right? What if they make sure that your drugs are available through the postal system and at the local grocery store where you're going anyway, right? What if the postal system, which is delivering fewer letters these days, right? What if they deliver your drugs because you need them and the postal service already works, it already gets to every door in America, and they need more, inventory to prop up those drugs. So I think there's a whole bunch of creative ways to think about, if we flip the whole thing, right? If the bottom line is like, what do we actually need as a society rather than what makes the most money, there are a whole bunch of ways to think about the assets that we already have and leverage them to make sure we're getting the healthcare that we need.
Yeah. Again, I'm really appreciating the systems view perspective, acknowledging there's a value chain, they call it, or value web in something like pharmaceuticals, which the idea there is to provide medicines that are critical for health and well-being. But what has at each phase or each stage, you've kind of outlined that there's extraction and profit taking, and then lobby and resistance to transformation because of the enormity of the extraction. And yet, simultaneously, at each stage, there's places and ways to intervene with more public and community-oriented options to triage or transition and ultimately transform. Like you said, the billions and billions of dollars in novel chemical entity and drug discovery and research and intellectual property protection is where a lot of that power is, and some very perverse incentives. And yet it's insulated itself. It's very difficult to go straight there. It doesn't mean we shouldn't. I didn't hear you say that, but there's all these other pieces where we can actually maybe have more purchase and action, leveraging existing infrastructure, existing assets and opportunities, and work our way towards a total systems transformation. So they're not mutually exclusive. Totally. Is what I'm hearing you say.
Absolutely. And I think a really important part is, right, I try to work on all of those fronts, right? I'm working on where can we how can we do public R&D? How can we do public manufacturing? How can we do the distribution? Could we have a wholesale employee ownership transition in the retail sector, right? So that all your CVSs are now co-ops, right? I'm pushing on all those fronts, and the idea is to lean into whichever door opens, right? But I think a really important point to say is even the stuff that feels smaller or not as impactful, or right, if we do distribution in a different way, or if we do a little bit of manufacturing here, if we're manufacturing one drug in the public sector or through a nonprofit, worker-owned entity, that feels small, but it's actually starting to take power back from that big corporate lobby, right? As soon as big pharma doesn't have a monopoly on our drug supply as a country, we've shifted the balance of power. And then that means that other policies are more possible, right? It opens up all this political space. So I think it's about all of these different ways that we can reclaim public power and build it little by little. Wherever the first puzzle piece falls is sort of irrelevant. Yeah, I want it to be at the top. It's okay if it's not, because it all helps us shift the economic power and therefore the whole conversation.
I love it. And it creates political possibility. I think it also animates the imagination of the public. And I hope Next Economy Now listeners have had their imagination animated by Dana's sharing of just pieces. We could do, I'm sure, a number of recordings to cover more of your important and consequential work. But thank you, Dana, for coming on the show to just share. Is there any last words, anything you want to say in the remainder of this episode?
Just that I hope listeners will reach out and tell me what I've missed too, because I'm constantly learning about both current and historical precedents and models. And I think, that it's on all of us, collectively to be creative and to do the work. And I want to be parroting back to the world the biggest and the best ideas. So also let me know. Right? But yeah, thanks so much. It's been a real pleasure to talk with you. And I hope it has been animating, and I hope it does give some folks hope despite the enormity of what we're up against.
Sincerely, thank you, Dana. I really appreciate you and all your work and your time today.
Next Economy Now is a production of Lift Economy. To listen to all of our episodes, go to lifteconomy.com/podcast. That's LIFT economy.com/podcast. You can also sign up for our monthly newsletter at lifteconomy.com/newsletter. Please also rate and review our podcast on iTunes, Spotify, Stitcher, or wherever you get your podcasts. Thanks for listening.